Guys, this is Charles. I'm one of the surgeons at Beecroft Veterinary Specialist and Emergency Center in Singapore. Today we have an interesting case, which is a cat that is very yellow. And so I'm not sure if the white balance captures it, but this cat basically looks like a banana. And so the question is whether it has intrahepatic hyperbilirubinemia or posthepatic hyperbilirubinemia. And so couldn't really tell from the ultrasound if there was a bile duct obstruction. And so we're doing an X-lap to try to determine what the source of the elevated bilirubin is. And my guess is that it has a biliary obstruction, but that has not been absolutely confirmed. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I'm doing a midline abdominal exploratory. And then we'll have a look around inside, try to express the gallbladder. If we can express the gallbladder, we're pretty much done except for collecting some samples. If I cannot express the gallbladder, then I'm going to have to do a duodenotomy. So I'm going to have to open up the small intestine and try to cannulate the common bile duct. If I can cannulate it easily, then we're pretty much finished, whereas if I can't cannulate it easily, then we have to figure out what we're going to do in that event, which may include a cholecystoduodenostomy. So that's liver right there. And a big gallbladder that I can already see. Do we have, we've got some Balfours there?
Balfour, the new one.
That'll be great. Okay, so that is a very large and nasty looking liver. I will pull this guy out here. Just assembling our Balfours. And we get some towel clamps here. We'll go ahead and put that spoon in. And I'm just using the towel clamps to keep the Balfours centered. All right, so the liver looks very abnormal. The gallbladder is pretty dilated here. Just look at the rest. Do my complete exploratory before I jump into looking at the biliary tree. So I'm looking at the diaphragm. That all looks pretty normal. You can see the vena cava there. See that?
Yes.
Vena cava with the hepatic veins going into it. You guys can't see that, sorry. Kidney. Where's the stomach? Here's the stomach. And I still have not established whether I can express the gallbladder. And so elevating here, we've got a huge, huge dilated common bile duct. So that is all common bile duct right there. And there appears to be a mass or something at the opening of the common bile duct into the duodenum. And so I don't think that that's going to be, I don't think we're going to be able to pass a catheter through that. And that is an unresectable mass as well. And so what I'm going to have to do is a cholecystoduodenostomy to try to bypass that. And if we can sample that, I'm not sure if we can, we'll try to sample that common bile duct. So looking down here, can see the vena cava sitting there, the renal vein left and right. Jejunum, really enlarged mesenteric lymph node here. So we'll be biopsying. Can we make a list of things that we need to biopsy? So we need liver, we need the mass at the opening of the common bile duct, we need mesenteric lymph node, we need to aspirate the kidneys. So look at the size of that mesenteric lymph node. That is really huge. Now we could never remove that because of all the blood vessels traveling through the mesenteric lymph node and into the jejunum. Okay, and then we've got colon here. Colon's a bit big and dilated. We've got some other lymph nodes that are enlarged here. Looking at the spleen. So spleen looks fairly normal. We've got an adrenal gland sitting here, and the left kidney is a bit enlarged as well. All right, so so our next step is going to be to do a duodenotomy. And can we get some saline soaked sponges to pack off the duodenum? So I'm not sure if you guys can see, but that is a really big mass sitting there. Question about, can a subtotal colectomy be done for megacolon in dogs? I don't think that I have done that in the past. I've done subtotal colectomies in dogs for masses and things. Can we get another lap sponge, please? Moistened. And I'll get some 4-PDS for stay sutures and some hemostats, please. Oh, we've got hemostats. That's great. Yeah, it's great. PDS, yeah. Now I'm fairly confident that that gallbladder is going to have to come out of its bed so that we can attach it to the small intestine. All right, so I like to put in stay sutures into the duodenum before I do my duodenotomy because I find it much easier to hold the duodenotomy open. And then I'll get a like a 5 French something, urinary catheter or feeding tube. I think I'm going to replace my other suture because I have them asymmetrical. Okay, let's just get suction ready.
It's okay. Can put over there.
Now when you're doing a cholecystoid, now that's bile.
Yeah.
When you're doing a cholecystoduodenostomy, you want to make sure that your opening is at least 3 or 4 centimeters. Now the problem is that I don't really understand. So that's the mass right there. Why it's so dilated if we've got bile in the duodenum. Do we have that catheter, or are we waiting on that still?
6 French, okay, no?
I beg your pardon?
6 French.
Yeah, we can try that. And it might be too big, which means we may have to go with a slightly smaller one. What's the next smaller size?
4 French, dollar French.
Okay, let's see if I can get this in. So I found the papilla. I think I found the papilla. So that's passing easily. Very strange. Let me zoom in for you guys a little bit. Alright, so I've been able to cannulate that common bile duct, but I'm not sure that I'm getting any bile out. Can I get a... So you want to be really careful when you flush this, because you can inadvertently flush bile back out into the hepatic duct. So that's flowing really easily. And if you guys can see the bubbles coming through. Alright, so we don't need to do a cholecystoduodenostomy, but I am going to leave this stent in. I'm just opening that up a little bit more so I can see what I'm doing there. That's crazy, this big tumor sitting here. And there are little polyps throughout. This is really something. All right, I'm going to take a biopsy of the polyp in the lumen. Get the table up just a little bit. Thank you. That's great, thanks. All right, so now what we're going to do is I'm going to cut this catheter off and do some intraluminal sutures. So I'm cutting that catheter off, and then I'm going to tuck this down the intestine like this. And then I'm going to take a couple of bites. Anise, can I get you to put your finger underneath there? And thank you. So I'm just going to anchor this cannula inside the lumen. Try not to stab Anissa's finger, although it's a sacrifice you got to make, Anissa. And then when this suture dissolves In a few weeks, he'll just pass that cannula out through his intestine, out through his feces. Can I get another 4-0, please?
Sorry.
All right, so we can release our stay sutures. So I'll just cut those off. All right, you can release your finger there. And what I'll do is I'll have somebody retract caudally there. Thank you. And I've gone a little bit past the end of the incision with my first bite to make absolutely sure that I'm overlapping that incision completely so I don't leave a gap. All right, so then I'm going to have retract on that. Do we have mosquitoes? Sorry, Adsons. You can see that I'm using the thumb forceps to direct where I want that loop to go. I'm going full thickness with my bites. You have to remember to do a feeding tube as well.
We need to send for culture as well, right? But is it gallbladder culture or?
Bile culture, yeah. Yeah, we can just culture what's in the syringe.
Yeah, we can. Thank you.
So there's a question about whether I could do a Billroth 1 or gastroduodenostomy, and I could not in this situation because we have to figure out how we would get the biliaries, the pancreatic secretions to get into the intestine, which if I resected that whole area, the pancreas, we couldn't allow for the pancreatic secretions to be released. And so we basically have a blind sac, blind end of the pancreatic duct. And so, all right, so now I've got a little problem here. And I'll tell you what that is. My loop, keep tension on that, please. My last loop of suture is loose. Okay? Now, seems like that would be a catastrophic situation, but it is not, and I'll explain how I'm going to fix that. I did promise I didn't do this on purpose to demonstrate this procedure. So what I'm going to do is I'm going to take an extra loop of suture, grab that with a hemostat. Grab that with a hemostat, please. Okay, so I've grabbed my loose loop of suture, and then I'm going to take an extra bite right next to my loose loop and tie a knot. Okay, so I've tied a knot next to my loose loop. And the problem is that if I don't manage this, that looseness is going to propagate throughout my entire line. So what I do now is I just tie to this one, and what's going to happen is that that suture is going to pull the loop through, and so I'm tying the knot to this little extended suture that I've created. Cool? So otherwise, the only thing that I could do would be to redo my whole suture line, which would be really annoying. Okay, so let's cut that down. All right, so now we need to probe. That wasn't what I was going to do, but you are absolutely right. So now I'm probing my whole suture line to see if I can pop through anywhere. That was just a slightly bigger gap between my sutures. I think the gap just looks big because I'm wearing loops, but I am going to put in another little extra knot there. Okay, now the next thing we're going to do is we're going to omentalize. A bit of omentum here. Here's some I prepared earlier. And we'll get a hemostat on this long tag and bring it cranially and just leave it over the liver. Okay. All right, so now for the next trick, we've got to start collecting our samples. So first thing we'll do is a liver biopsy. Might want to zoom out if I can.
I think so. Or is it a right lateral? Right medial.
Right medial. Right next to the gallbladder.
Right medial.
Okay, now we will sample the mesenteric lymph node. I might use a blade. Just be really careful not to go too deep and inadvertently get the mesenteric artery. So next we'll get a kidney FNA. Did she want both kidneys or just one?
Both kidneys.
All right, so this is left kidney. So I'm aspirating the kidney.
Please, thank you.
And this is going to bleed, so go ahead and take that needle. So I'll just hold that off for a few minutes. It's a lot of blood. Question whether full thickness, I assume that means when I'm doing the omental patch, and yeah, I do go full thickness. So hepatic duct obstruction, look, you could have an individual hepatic duct obstruction on one side or the other, but given the fact that we've got this mass at the level of the major duodenal papilla, that's probably what's causing the issue. And that being said, doing this stent is not going to provide a durable long-term solution, but hopefully with a biopsy, we'll be able to identify what's going on there and maybe treat it otherwise. I'm thinking this cat maybe has lymphoma or something.
Is that new needle? Yes.
So here's the other kidney. Trying to go a little bit more peripherally.
Another syringe. 3 ml. Thank you.
I may try to get a sample of that mass here as well, exteriorly, just to make sure that I'm getting a diagnosis. Grab that with a thumb forceps, please. Just grab that. Okay. Might try to get another piece of that.
Do we sample it separately or put in the same pot?
Probably separately.
Okay. Second passive one.
Can I get a number 11 blade, please?
11 bit, thank you. You don't need to. Uh, 11 blade.
Thank you. You grab that with the, grab the,
Oh no.
yeah. Now we got some new gel foam stuff called Lysa Stiff. Thank you. So this is a 12-year-old cat? 12-year-old cat who presented with a history of jaundice and inappetence. So we got this new Lysa Stiff, which is the purified bovine collagen. Just make sure I'm getting some leakage here. I just want to make sure that I'm not communicating with the... I just got some edematous fluid out of it. And I just want to make sure I haven't gone into any lumen or anything. No. All right, so go ahead and open that up and give me about a 2x2 sheet.
2 by 2 centimeter or 2 millimeter.
2 centimeter by 2 centimeter. That's 2.3.
Sorry. I tried my best.
All right, so...
So this is the bovine purified
Yeah.
collagen.
Yeah.
Purified bovine collagen.
Maybe too big a piece. Can we cut that into maybe a 5 by 5? 5 by 5 mil? Just hold that on there. Is that bleeding as well?
Sticky.
See how it just sticks on and That's it.
Cool.
Isn't that cool?
Yeah. You gonna take this?
I don't want to make something else bleed.
You still got that?
Liver biopsy yet? Common bladder,
Yeah.
It's not. Yes.
Let me get another little small piece of the last dip. The only problem with this stuff is that it's sticky. It sticks to your fingers. Yeah, now you leave it in. Yeah. Okay, so let's get some warm saline.
Many instructions, so it's not one. What? The instruction or the thing?
Oh.
Okay. You can just put warm behind there, please. Thank you. Hot warm.
Anything else we've missed?
No, we got both FNAs, liver biopsy of one lobe, biopsy of the mass. I actually have a question. After we place a stent, do we usually try to compress the gallbladder again to see if it?
No, we just let it go passively. Yeah.
Okay. All right.
Can you get some 2 OPDS, please? And a larger needle driver, please. We might need to open one up.
And we need 2 and 2 JP.
All right, so I've got a question for you guys, both watching on the YouTube channel and in-house. 2 OPDS. Yeah. In what situation would we do an esophagostomy tube? In what situation would we do a gastrostomy tube? And what's the advantage and disadvantage of each? So,
For esophageal tube, you can use it for most situations that doesn't need a bypass of the esophagus.
sorry?
My understanding is that for esophageal tube, you can use it for any condition that doesn't require, you can use it for most conditions.
Yeah.
However, if there's any condition that requires bypass of the esophagus, like if there's esophagitis or if there's like esophageal surgery or tear, then we'll do a gastrostomy tube.
Okay, so Chessie in-house has said that your preference would be to use an esophagostomy tube unless for some reason you have to bypass the esophagus, which would be if you've had esophageal ulcers or esophageal surgery or esophageal foreign body or something like that. And that's exactly right. So we always want to use as much of the gastrointestinal tract as we can. The other situation where you can't use an esophagostomy tube is in the situation where the patient is unconscious and doesn't have a swallow reflex. So the advantage of an esophagostomy tube over a gastrostomy tube is that you can, if an esophagostomy tube is removed prematurely, you're not going to get peritonitis, whereas if a gastrostomy tube is removed prematurely, you can get peritonitis. And so gastrostomy tube we can remove immediately after surgery if the cat's eating. whereas a gastrostomy tube has to stay in for 10 days to form a proper stoma. So in what situation can we not use a gastrostomy tube? Gastrostomy or esophagostomy, like neither one of those will work. What situation would that be?
That's when both bypass of the stomach and the esophagus is needed. Then we do a duodenotomy tube.
Right, and so what situation would that be? Big one is protracted vomiting. So if you have vomiting that can't be controlled medically, and you're still trying to hyperalimate the patient, you have to go past the stomach and go under the duodenum or the jejunum.
Okay.
What's the disadvantage of a duodenostomy or jejunostomy tube over a gastrostomy or esophagostomy?
So you can't really, my understanding is I don't think you can send it home.
Okay, you can't send it home with the jejunostomy, and the reason is that you can't feed their normal food. You have to feed a liquid diet that's basically an elemental diet into the jejunostomy or duodenostomy tube, whereas with the gastrostomy or esophagostomy, you can feed them basically blenderized normal food. And then the other issue is that you can do intermittent feeding with gastrostomy and gastrostomy and esophagostomy, whereas with a jejunostomy or duodenostomy, you have to do continuous feeding because there's no storage capacity of the stomach. So you can't do boluses. That can come out, thanks. That was the other e-learning thing I did, was tube feeding.
Oh, nice.
So I can give you guys access to that as well.
Thank you.
Assuming I can get into my program. If not, I'll have to do it when I get back to Melbourne.
PDS, okay, for the subcutaneous?
Yes, please.
Okay. Thank you.
And I might have stopped prematurely. Nope, all good. All right, so I'll go to the live stream chat and see if there's anything that I have not answered. And then what we'll do is when we finish this surgery, I will do the esophagostomy. Unless, are you happy doing esophagostomy tubes?
I'm happy doing
Okay, so Chessie's going to do the esophagostomy, and I will just read and see if there are any questions that I haven't answered. So Tom says the disadvantage of a gastrostomy is that it needs to be surgically removed, whereas, and that is almost right. You can remove a gastrostomy tube non-surgically as long as it's been in there for about 10 days and it's formed a stoma. Gastrostomy, if concerned about esophageal pathology and tear. Yep, that's exactly right. I've had an invitation to North Africa. That would be really fun. I think I'll have to take the whole team, though. Algeria, working in the Czech Republic. So preoperatively, this cat just had a lot of blood work, and then it had an abdominal ultrasound, which confirmed the fact that it had dilated common bile duct. So I do a single layer when closing the duodenum and going through the full thickness. And I'm using 4O PDS in a simple continuous suture pattern. So absorbable versus non-absorbable to suture that cannula in. Non-absorbable is going to be in there for 6 months, and I would be concerned about a foreign body reaction and ascending infection around that cannula if it was in there for an extended period of time. So we really want it to pass, within 3 or 4 weeks. And hi, Rick in Townsville. All right, guys, so that's pretty much it. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding in your phone the next time we live stream. And we will see you, hopefully, again tomorrow. Okay. Be me.